just to introduce Dr. Tolin, everybody, he is the director at of the Anxiety Disorders Center at the IOL. He's a professor that I had during my training at the IOL, and I learned a lot from you, so thank you very much. He is a graduate of the University of Washington, where he received his undergraduate degree, and then University of Arkansas for his doctoral degree. He did an internship in Boston, and he is also a faculty member at Yale. So we're very happy and privileged to have you here today. He'll be talking about cognitive behavioral therapy for anxiety disorder. So I'll turn it over to you to Dr. Tolin, and thanks again.
Well, thank you very much, Joe, and it's a pleasure to be able to speak with you about CBT for anxiety today. So my understanding is that I'm going to talk for about an hour, and then we're going to hopefully have some time for questions and answers. So keep those questions, coming. I think that what we'll do is at the conclusion of our talk, I will open it up for questions. And if you feel comfortable just unmuting yourself and yelling it out, that's great. If you'd rather type it into the chat box, I'll keep an eye on that as well. So let me just start by pointing out that when I talk about anxiety disorders, understand that I'm referring to the most common kind of mental disorder that there is, by a pretty significant margin. The anxiety disorders are significantly more common than mood disorders are. They're significantly more common than impulse control and substance use disorders are, infinitely more common than psychotic disorders are. So recognize that we're talking about a very common problem. And if you look within the anxiety disorders, I've got a bunch of abbreviations down at the bottom, which I'll explain. But you see that there are some that really stand out. So, things like, panic disorder, I'm reading from the left here, panic disorder and agoraphobia have a somewhat lower prevalence. Things like specific phobia and social phobia, really high. Generalized anxiety disorder and PTSD, also fairly high. OCD, less so. Separation anxiety disorder, surprisingly high, at least with a lifetime prevalence. So these are, again, very common, and the phobic kinds of disorders seem to be particularly common. Now, one of the things that's worth noting is that when you see a patient with an anxiety disorder, chances are they have had their condition longer than your other patients have had their conditions. And this shows, among whether we're looking at panic disorder, I'm again reading from the left here on the bottom, panic disorder, agoraphobia, specific phobia, social phobia, generalized anxiety, PTSD, social anxiety, that there's this delay in treatment seeking that is way above what you see in the delay in treatment seeking for other conditions like major depressive disorder, dysthymia, bipolar disorder, ADHD, alcohol abuse and dependence, or substance abuse and dependence. Usually, those also are unacceptable delays, but when somebody has one of those conditions, they tend to get themselves into treatment a lot faster than they do when they have anxiety. So the problem that we run into there is that when you get a patient with an anxiety disorder, chances are it's not a new anxiety disorder. In most cases, this has been sitting around for 10 or more years by the time they even first start to talk to somebody professionally about it. And the extra sad part of this is, let's say you go the 10 plus years and you finally seek treatment for your anxiety disorder. Chances are pretty good that you're not going to receive an evidence-based treatment for that anxiety disorder. So again, this is epidemiologic research, but what you can see is, perhaps not surprisingly, most people with anxiety disorders get no treatment at all. But when they do get treatment, the odds are only 50-50 that treatment is going to be an evidence-based approach. So that's part of what I'm hoping to correct, through talks like this. So let's start to talk about our conceptualization. And I always like to start here. I thought there's a lot of ways I could structure this talk, and I could just say, well, here's the recipe for treating PTSD, and here's the recipe for treating panic disorder, and we could do that. But ultimately, that's not going to be terribly satisfying as a clinician, because your patients are complex, and they come in with multiple conditions and comorbidities. And so you need to be able to think about their condition rather than just follow a treatment manual. So we really have to start with the primary question of why is this patient anxious? And it is important for us to think about the question why from two different angles, because I think there's two different kinds of why in behavioral health. The first kind of why is etiology, which is where did the anxiety come from in the first place? Now, that kind of why tends to be more favored by my more psychodynamically or psychoanalytically oriented colleagues. In CBT, we're also interested in why, but we have a different kind of why. Our why in CBT tends to be maintenance. That is, not necessarily where did the anxiety come from in the first place, but why is it still here? What's propping it up and what's causing it to persist day in and day out? So in CBT, again, we're very interested in why the patient is anxious, but within that question of why, just recognize that we tend to focus more on maintenance of the disorder than we do on the etiology of the disorder. And just to kind of expand on that a little bit, I mean, it's important to recognize, and maybe this will just seem self-evident, that the reason that any given problem started may not necessarily be the reason that the problem continues. Now, let's take smoking as an example, right? I mean, just imagine that a patient comes to you for smoking cessation and you ask about the etiology of that problem. And the person will probably say, if they're like the typical smoker, well, I started when I was in junior high or high school and I wanted to be cool like the other kids. Okay, so assuming your patient is an adult, one way that you could go would be to say, well, let's talk about how to resist peer pressure. But your patient is probably going to look at you like you're nuts, because that's not why they smoke now, right? If you fast forward and say, well, why are you smoking now? You get a very different why. The answer is, well, why did you smoke today's first cigarette? And the answer is going to be because I was in withdrawal. I was craving it. It's a habit, etc. So you might then say, okay, well, then our treatment strategy might be to help you learn how to manage or correct those withdrawal symptoms or try to reduce the habit. Hopefully everybody gets that distinction, right? We're interested in etiology, but we really make therapy out of maintenance. And so as I talk to you about why people are anxious, understand I'm mostly going to be talking about maintaining factors, not necessarily where anxiety comes from in the first place. So what processes do we know maintain anxiety? I'll talk about each of these in turn, but they are avoidance of feared stimuli, maladaptive beliefs about threat, a feedback loop in terms of brain and peripheral physiological arousal, and in some cases, deficits in behavioral skills. So let's talk about each of these. Let's start by talking about avoidance. This is baked into the DSM-5 definitions of most of the anxiety disorders, that our patients who are anxious tend to avoid things that are scary. Now, the things that are scary and the things that get avoided could be either external to the person, which is easier for us to recognize, right? I mean, if the patient doesn't do certain activities, or they don't go certain places, or they don't engage with certain people, that's a fairly straightforward form of avoidance to spot. But on a more subtle and difficult to detect level, avoidance can also be of internal stimuli. So some of our patients, for example, might avoid their own memories, or they might avoid their own thoughts, or they might avoid their own emotions or their own physiological sensations, right? That's a little tougher to spot, but it is still avoidance. So when we talk about external stimuli, right, there's all kinds of examples that we could think of from our own clinical practices, right? A patient with agoraphobia doesn't drive, or they don't go to the shopping mall. Or a patient with OCD doesn't want to touch anything that is dirty. Or our client with specific phobia doesn't want to go near a dog. Or our client with social anxiety doesn't want to speak in public or interact with people. Or a patient who has PTSD related to a motor vehicle accident doesn't drive on the highway anymore. Or a child with separation anxiety disorder doesn't want to be away from their caregivers, including sometimes going to school. Or a patient with illness anxiety disorder might avoid going to their doctor for fear of having bad news, right? So each of those are kind of, I think, fairly easy to spot examples of avoidance of external stimuli. But when we think about avoidance of internal stimuli, which is a little harder to detect, but still important, we see examples like this, right? A client with panic disorder might avoid experiencing elevated heart rate or avoid getting dizzy by limiting their exertion or limiting their emotional arousal. Or our patient with PTSD might try to avoid memories of traumatic events. Or a patient with OCD might try to avoid certain thoughts that they find to be forbidden or repugnant. And there's an even more subtle variation of avoidance, which we refer to as safety behaviors. And the idea behind safety behaviors are these are the little micro adjustments that the patient makes to their situation to make them feel better or to potentially prevent something bad from happening. So an example would be patient with OCD accidentally touches something dirty. So what do? They go and wash their hands over and over again. That's a safety behavior, right? It is still a form of avoidance, right? I'm doing something to avoid contact with contaminants. Or if our patient has social phobia, right? Okay, maybe they do go to the party, but they have to have a couple drinks in them first before they do it, right? That's a safety behavior. It's a subtle avoidance. Our patient with agoraphobia, fine, they'll go to the shopping mall, but they only do it when their spouse is with them. Or our patient with that motor vehicle accident related PTSD might drive on the highway, but they only do so in the right lane at slow speed in very light traffic, right? So these are also variations of avoidance. They can be tough to spot because it's not like the patient is blatantly not doing something, but they're making those micro adjustments to make it feel better for themselves. And that still serves the function of avoidance. Now, you might be thinking, well, that sounds pretty good, right? I mean, if something is scary, don't go near it. Okay, fine. But there is a problem with this. And in order to illustrate the problem, I want to take you back to a research study that was done in the 50s. So these folks were doing classical fear conditioning with dogs. So what they did was they were using shock training. So they put the dog in a box. The box has an electrified floor that's hooked up to a shock generator. Now, they turn on a red light. And then they hit the shock generator and the floor is electrified. And the dog freezes up because that's what a dog does when he's afraid. And then they turn on the red light and they hit the shock generator and the dog freezes up, and they do that over and over again. And eventually, as classical conditioning would predict, they could turn off the shock generator, just turn on the red light, and the dog still freezes up. So now the dog has learned to be afraid of the red light, right? We knew that, right? What these researchers were really trying to get at was, once a fear is instilled, how does the dog get over it? So these guys were really interested in recovery from fear. So here's what they did. They had a couple different groups of dogs who had all learned to fear the red light through this shock generation, this shock training, right? So they open up a second compartment to the box, compartment B, which you see here on the right side. Okay. Now, compartment B had never been used for shock. So basically, as far as the dog knows, that's the safe zone. So they put the dog, and you'll see between compartments A and B, they put a low wall, right? Dog can easily jump over it, right? So they put the dog in compartment A, which is where the shocking had always happened. There's no shock generation. There's no shock, button anymore. It's just the light. But they put the dog into compartment A. They turn on the red light, and the dog, being no dummy, jumps over the fence into compartment B. Then they put the dog back in compartment A. They turn on the red light, and the dog again jumps back into compartment B. And they just do that as long as needed, right? That was one group of dogs. The second group of dogs had the exact same paradigm, but the only thing that they changed was that they made that wall higher. So now the dog can see into compartment B, but he can't get to compartment B. So they put the dog in compartment A, they turn on the red light, and I'm assuming the dog looks longingly over at compartment B and says to himself, boy, I sure wish I was over there, but he can't get there. Right, so you got two groups of dogs here, right? One group of dogs can easily jump the fence and get away from the red light. The other group of dogs can't jump the fence and therefore can't get away from the red light. So just as a thought experiment, think about what you know about anxiety. Think about what you've seen in your patients. Think about what we've been talking about so far, and just think to yourself, which group of dogs do you think got over the fear? Was it the dogs who could get away from the red light? Or was it the dogs who had to stay there? Well, if you guessed that it was the dogs that had to stay there that got over the fear, you're absolutely right. In fact, the results were striking. When the dogs had to stay there, that is, when they had to stay in the presence of the red light, about 95% of them got over, 90 to 95% got over the fear. When they could jump the fence and get away, exactly 0 of them got over the fear. So what does this mean in terms of our patients, right? What it means is that avoidance causes the maintenance of fear. And the corollary of that is you cannot avoid and overcome fear at the same time. It is an impossibility. I've seen lots of well-meaning clinicians who encourage their patients to avoid things that make them uncomfortable. As we can see here, not a good idea, right? All that's going to do is cause the anxiety to persist. Now, we as clinicians cannot erect walls and prevent our patients from avoiding, nor would we want to. But as skilled therapists, we use our powers of persuasion to help the patient understand that they really should stay in the scary situation until they start to feel better. Now, another maintaining factor that I mentioned is maladaptive or distorted beliefs about scary things. The way this works is this. I mean, let's imagine you have a patient with OCD, right? So they see the toilet and they get very scared, right? From the cognitive perspective, the way that we would say this is that the toilet is not what scared the patient. What scared the patient was their appraisal of the toilet. And in particular, they thought that it means danger of some kind. The idea here then is that it is not the situation that is scary, rather it's our interpretation of that situation that frightens us. So the person's thoughts and beliefs about various situations, objects, or activities are what causes the emotional discomfort. And it's important for us to recognize that not all thoughts and beliefs are accurate. And in fact, our patients with anxiety disorders often have very inaccurate thoughts and beliefs about the things that they're afraid of. Those inaccurate beliefs we sometimes refer to as cognitive distortions. And here's a couple of examples of cognitive distortions, right? So, I mean, and there's lots of variations on this. This is mine, but you know, some of our patients engage in what we might call probability overestimation. So they're taking something that's probably not going to happen and talking to themselves as if it's very likely. If I go to the mall, I'll have a heart attack. Some of our patients engage in what we might call catastrophizing, which is making something out to be a bigger disaster than it really needs to be. Like if I faint in public, which is bad, I'll be so embarrassed that I'll never recover. Well, that's kind of magnifying it and making it a big disaster, right? And so on. I'm not going to go through the entire list, but just know there are sort of predictable errors in logic that our patients make. And I'd say within the anxiety disorders, probability overestimation and catastrophizing tend to be the most likely suspects, right? You're either telling yourself that some unlikely event is really likely, or you are telling yourself that if something bad happens, it's going to be the end of the world, or both. Now, I also mentioned there's this kind of feedback loop of physiological arousal. And when I talk about physiological arousal, what I'm referring to is the sympathetic nervous system, right? So it starts in the brain. but goes down and stimulates a cascade of peripheral biological reactions. The pupils dilate, you stop salivating, your heart rate goes up, your digestion shuts down, etc. Right? And what's happening, if you look a little bit down in the diagram, a big piece of what's happening is that your adrenal glands are secreting epinephrine and norepinephrine, right? And that's going into the bloodstream. That's not a permanent thing, but that's what kind of causes a whole skyrocketing of anxiety-like physiological symptoms. And what happens, and then this is tricky, and this is based in part on what's called the somatic marker hypothesis, is our brain pays attention to what the body is doing. So it's kind of an interesting back and forth, right? The brain initiated the process of the sympathetic nervous system, but then the brain looks at the sympathetic nervous system, looks at how active it is, and essentially comes back with the conclusion of, oh, this must be a really bad situation because look how anxious and aroused I am. So our emotions and our decisions then are partially being driven by how our brain interprets our physiological sensations. And then the last piece that I mentioned in terms of a maintaining factor is deficits in behavioral skills. And what we find is that sometimes people engage in a behavior either because they don't know what else to do or because they're not particularly good at other more adaptive behaviors. And a couple of the skill deficits that come up a lot when we talk with our anxious clients is social skill deficits and problem-solving deficits. So when we talk about social skills, what I mean by that is what you say, that's verbal, how you say it, like that's your nonverbal cues. And I just will make a note that there's a subset of social skill called assertion, which is a particular kind of social skill that involves saying no to people or asking for what you want. And many of our anxious patients are really not very good at this. So again, if you just sort of think about that, if you're not good at that basic skill, chances are you're going to fall back and use some more maladaptive behaviors like avoidance. Right? So a part of what we want to think about then is how do we build the skill so the patient doesn't have to rely on avoidance. The other kind of skill deficit that I mentioned is the problem-solving skill. So, and by problem-solving, what I mean is just that life throws us all kinds of curveballs. I mean, you and I have probably experienced some curveballs already today. Maybe your car wouldn't start, or something was knocked over in your garage, or you couldn't find something you needed on your desk. I mean, those are problems in life that for most of us are not a big deal. But for many of our anxious patients, they become this obstacle that they can't get past. So when we think about sort of like some people are good problem solvers and some people are bad problem solvers, when you look at the distinction between the good and bad problem solvers, here's what tends to shake out. One is that good problem solvers tend to have a generally positive orientation toward problem solving. That is, they tend to believe that most problems in life are solvable. You know, people who are not so good at this tend to immediately jump to the conclusion that problems in life are intractable. The good problem solvers, if they're going to solve a problem, either, you know, they define the problem, they try to figure out what the cause of the problem is. They generate multiple possible solutions to the problem. They do this largely intuitively, right? And I could do this or I could do that, right? And so you're kind of balancing it out. Again, bad problem solvers tend to just grab the first solution that presents itself, whether or not it's a good idea. And then you decide, you know, based on kind of the merits of each possibility, which solution you're going to do. And then you try it out and determine whether, in fact, that did solve the problem. So there's steps. And again, you know, most of us, this is just intuitive. We don't even have to think about it. But for many of our anxious patients, this is a foreign language. They are just not used to approaching problems in this way. So when you see a patient like that, there may be some skill building that we want to do for that patient. So let's talk about how all this stuff goes together into into all this case formulation that we've talked about, how that goes together in terms of our understanding of CBT for anxiety. First of all, as you probably know, CBT is an evidence-based psychological treatment for anxiety. In fact, I think there's good data to suggest that it is the best thing you can do for anxiety disorders. And the idea behind CBT for anxiety is that it aims to interrupt those maintaining mechanisms, right? So again, we're not chasing the etiology. We're trying to figure out what's propping this problem up and causing it to stay alive, and can we cut those maintaining factors out? So how do we do that? Well, there's kind of a limited number of core interventions that we use for anxiety in CBT, and they involve exposure to avoided stimuli, the correction of maladaptive beliefs or cognitive distortions. For some, not all, and I'll talk about the distinction here, but for some, it may involve a training in relaxation to drop down the peripheral physiological arousal and therefore interrupt the feedback loop. For some, when there's a behavioral skill deficit, it may involve training them in the necessary behavioral skill. So let's talk about those pieces, right? Let's start by talking about exposure. What do I mean by that? Well, the idea behind exposure is that we're asking the patient to face or confront things that they find distressing. And again, just as we were talking about avoidance, right? Sometimes the thing that we're trying to expose them to is external to them. So I want you to come into contact with the feared object or activity or person. Sometimes, however, what we're trying to expose them to is internal to them. I want to expose you to those thoughts or memories or body sensations that you've been trying so hard to avoid. Really, what we're doing throughout all of this is we're trying to reverse that pattern of avoidance that is so powerful in maintaining fear. So there's a couple of different ways we can do this exposure. One is in vivo or real life exposure. Another is called imaginal exposure, using the imagination to generate a scenario. We might use exposure to thoughts, like have the person deliberately think the thing they don't want to think. We may use a variation called interoceptive exposure, which is direct exposure to feared bodily sensations. Well, let's talk about each of these, right? In vivo exposure, if you have a patient with snake phobia, best thing you can do for that patient is go find a snake, right? And, build up to it, but eventually get the patient coming near the snake, touching the snake, holding it. That's the most straightforward and effective thing you can do, right? If the patient is afraid of flying, and I understand this could be cost prohibitive for many, but the best thing you could do is get them on an airplane, right? If your patient has social phobia, you could encourage them to say, give a speech in front of an audience. Or if you have a patient with OCD, you might ask them to touch things that seem dirty or germy. That's in vivo exposure. The imaginal exposure is when you can't do in vivo exposure, or you shouldn't do in vivo exposure. And that sometimes means just kind of thinking through worst case scenarios, right? So when the patient has OCD, we might do some in vivo exposure, like have them touch something that seems dirty, but then I might want them to deliberately imagine dying of some terrible disease. Well, let's think about it. I know you're trying not to think about that, but let's go ahead and think about it. If you have a patient who's afraid of flying, right, it sometimes is hard to get them on a plane, especially repeatedly, but you could have them deliberately imagine being on a turbulent flight, for example. And we actually, over here at the Anxiety Disorder Center, use virtual reality to assist with that sometimes. Let's really pretend you're on an airplane. If your patient has PTSD, we might ask them to deliberately recall their trauma memory. Again, you've been trying so hard not to think about it. Now I want you to do the opposite. I want you to actually think about it and confront it. The exposure to thoughts, that comes up a lot in our treatment of OCD. So if the patient has these sort of blasphemous or repugnant or sinful thoughts, like a lot of our patients with OCD might have the thought, the intrusive thought, I'm a child molester. And that really freaks them out and they try not to think about it. And of course, it just gets worse. So we might encourage them to think deliberately, I'm a child molester. Let's think it over and over and over again, right? If you have a patient who has certain bad words or mental images or phrases or numbers, let's think about those things. Let's let them be in your mind rather than try to get them out of your mind. This, by the way, I would just note, I mean, if you're a student of like old school CBT, you know, there was a strategy that they used to use a really long time ago called thought stopping, in which the person would have an intrusive thought and they were supposed to scream stop at themselves or snap a rubber band. And of course that didn't work. And you can imagine why, right? It's avoidance, right? And for us as therapists to facilitate the avoidance wasn't really doing the patient any favors. Interoceptive exposure, as I mentioned, is that exposure to body sensations, right? So what we're really trying to do is confront the physical sensations that the patient is afraid of. So if your patient is afraid to be dizzy, then one of the things that we might do is have them get dizzy. Let's turn around or spin in a swivel chair or something like that, or just shake your head side to side until you feel woozy. If your patient is afraid of lightheadedness or they're afraid of paresthesias, those numb tingling sensations, you could have them hyperventilate and bring it on. If your patient is afraid of increased heart rate or they're afraid of sweating, we could have them run in place or run up and down stairs. And I'm talking about this very literally in the session, right? It is not uncommon if you were to be a fly on the wall in my office to see me jogging in place with a patient or putting them in my swivel chair and turning them around as they're dizzy, right? So we do these things in the session. You get the idea, right? If the patient's afraid of a physical sensation and they're trying to stay away from it, the best thing you can do is reverse that process and try to get them to, you know, gradually confront the very thing that they're afraid of. Now, I also mentioned this issue of safety behaviors, right? These are the little micro adjustments that people make to make it feel okay. We need to recognize that that also is avoidance. So what are we looking for when we talk to our patient? Well, when your patient has OCD, the safety behaviors are really obvious, you know, usually pretty easy to spot, right? It's the compulsive ritual. It's the hand washing, it's the arranging, it's the repeating, right? All of those are safety behaviors. But some other things that may be a little less obvious are when the patient has to carry their medication with them. Like I always got to have my PRN benzodiazepine with me. Even if I don't take it, I just feel better having it. That's a safety behavior. Some patients just have to have their cell phone with them or they have to carry pepper spray. Some of our patients use alcohol or drugs as a way of trying to calm their anxiety to take the edge off. Some of our patients need to have a safe person with them in order to be able to do a particular exposure. And the problem with these safety behaviors is, as I mentioned, they're a form of avoidance. And they're a particularly pernicious form of avoidance because what they're doing is these safety behaviors are teaching the brain the wrong lesson. And what I mean by that is what throughout the process of therapy, we want the patient and we want their brain to come away with a lesson of unconditional safety, which is just, I'm safe, this is fine. When the patient uses a safety behavior, it teaches them a lesson of conditional safety, which is I'm safe if. I'm safe if my spouse is with me. I'm safe if I have my benzodiazepines with me, etc. Right? Which is not really what we want the patient to learn. We want them to learn that this is actually just safe. And also, you know, like any other kind of crutch, these safety behaviors kind of discourage more healthy ways of coping, including, by the way, not really doing anything and just letting the anxiety pass. So the patient gets kind of hooked on this compulsive or safety behavior, and then it seems like they can't get it, they can't give it up. Now, as a side comment on that, what I would say, remember I mentioned that like relaxation training was one of the components that we might use, and then I put in parentheses for some. And here's the reason why I say for some. Sometimes relaxation doesn't help and actually may get in the way, right? Now, it used to be when we were doing exposure, you know, again, kind of old school CBT, we had this thing called systematic desensitization. And in systematic desensitization, you were doing some like at least imaginal exposure while doing a relaxation exercise. But, as they gathered more and more data about that, it became clear that relaxation didn't have anything to do with it. It was just the exposure. And as you can see in this graph, this is results from patients with panic disorder in particular, in which patients were randomized to either receive exposure and nothing else, or they were going to get exposure with a nice relaxing breathing exercise. And what you can see is that when the patients got the breathing exercise in addition to their exposure, they actually did worse than they did when they were just given exposure by itself. And why might that be? Why would a nice, just relaxing breathing exercise actually get in the way? And I think the answer is because it became a safety behavior, right? It's a crutch, and it teaches the patient, I'm okay as long as I can breathe right. Well, in the middle of a panic attack, you're not going to breathe right. So then it just gives the patient more reason to go, right? So what we're really trying to help the patient do is recognize you don't have to relax. You don't have to feel better. You don't have to calm down. You don't have to do these things to make it okay. You can be okay just because the situation is safe. It's not because of all these little things you do. Now, you might be asking, well, what about those PRN benzodiazepines? Could that be a safety behavior? And the answer is yes. So here's some more data from panic disorder, right? In which patients either received exposure alone, all by itself, or exposure with a fixed dose benzodiazepine, or exposure with a PRN as needed benzodiazepine. What you can see is that the addition of a PRN benzodiazepine detracted from the outcomes. That is, popping alprazolam when you're anxious, turns out, actually gets in the way. It makes the problem worse, not better. And again, we can think about why that might be, right? It's a crutch. It's a safety behavior. It only serves to teach the patient I'm safe as long as I can pop a pill, which is not really what we want them to learn in therapy. We want them to learn I'm safe because there's nothing bad happening to me. That's why I'm safe. So in practice then, we have to eliminate those safety behaviors in conjunction with our exposure. And we call that response prevention, right? Stop engaging in behaviors that give you short-term relief, but ultimately keep you stuck, right? So don't engage in compulsions. Don't wash your hands. Don't take your benzodiazepines prior to or just after your exposure. Don't relax during exposure. And don't bring the safety items or the safety people with you, right? I want you to learn that it's really okay, even if you don't do those things. So that may lead to you to ask the question, well, geez, if my patient shouldn't relax and they shouldn't take benzos, then how are they supposed to cope with their feelings of anxiety? And my number one answer to this is I often encourage the patients to practice what I call the art of doing nothing. Sometimes the best way to cope with anxiety is not to cope with anxiety. Just sit there, right? Anxiety is not permanent. It goes away. It is not necessarily something that you need to cope with. You can wait it out. And often that's the best strategy for our patients. What I'm really trying to do then is I'm trying to emphasize not the elimination of anxiety, but rather the tolerance of anxiety, right? We call this distress tolerance. I want you to practice tolerating these uncomfortable feelings rather than scrambling to try to make them go away. And what I'm really trying to get my patient to learn here is that I can be afraid and it's not the end of the world. And I don't necessarily have to do things to try to make myself feel better. In fact, when I do things to try to feel better, that usually makes the problem worse. Now, on the cognitive side of things, remember there's those kind of cognitive distortions, right? So one of the things that we're going to be doing here is trying to elicit the patient's interpretations of the things that are scaring them. And here, what we're trying to emphasize is what cognitive therapists sometimes call hot thoughts, right? As opposed to cold thoughts. Cold thoughts are just narrative, but every now and again within that narrative, there's a hot thought, something that's really emotionally evocative. So, there goes a dog. That's cold thought. That's just a narrative. But if the patient says, yikes, that dog's going to bite my face off, well, that's a hot thought. That's emotionally evocative. So we as therapists use Socratic questioning as a way of helping the patient sort of think that through. Okay, so we're not telling them the dog's not going to bite your face off. We're actually encouraging them to start to come up with the answer by asking really pointed questions about it. And one of the things that I will sometimes do, not always, is send the patient home with some homework to write down their interpretations when they're anxious. And I'm sorry, this is an example from a patient who's depressed, not anxious, but you get the idea, right? On the left, what's the situation that bothered you? On the right, how were you feeling? But in the middle, and this is the really important part, is what did you think about it? What were your interpretations that might have contributed to that upset feeling? We then go back and I talk to the patient about those cognitive distortions like we talked about. So I introduce them to the concept that not everything you think is accurate, and there are actually some predictable errors in logic that you might be making. And then I start to challenge those thoughts, right? And one of the most straightforward ways to do that is to ask the patient to examine the evidence. What is the evidence for this interpretation? What is the evidence against this interpretation? The analogy here is let's put the thought on trial, right? Let the prosecution make its case, let the defense make its case. Let's have a little cross-examination, right? What evidence do you have that tells you you're going to have a heart attack in the mall? And what evidence do you have that tells you you're not going to have a heart attack? You know, again, I'm not telling, this is Socratic questioning, right? So I'm not telling them you're not going to have a heart attack, but I'm asking them to sort of think it through. We could also encourage the patient to consider alternatives, like just sometimes a gentle question like, well, is that the only way to think about this? Can go a long way. Or what do you think somebody else in this situation would think about it? Would they reach the exact same conclusions that you did? And we can use what are called behavioral experiments, which is actually to test it out. So some of our patients' thoughts or interpretations take the form of if-then statements, right? If I go to the mall, then I'll have a heart attack. If I imagine my trauma, I'll have a meltdown. So, okay, that's a hypothesis, right? So we treat it like a hypothesis and we construct an experiment. Well, let's try doing that thing, but let's pay very careful attention to whether the thing that you're afraid is going to happen really happens. So let's come back and talk about it, right? So essentially, we're using the patient's experience to give them a bit of a reality check. I may send them back home with some homework, again, to sort of think about what cognitive distortions they might be having and to actually jot down what are some alternatives to how I might think about this. So if this patient, you know, is again depressed and thinking like, I'll never succeed in this job and I'm such a screw up and I'll probably get fired, right? I might ask them, check off what cognitive distortions seem to be present here. What do you think about that? And then can you replace it with something that's a little bit more rational and not distorted? And then just kind of as a check on yourself, see, does that change how you feel? And usually it does. Now, I also mentioned there's that feedback loop between brain and body. So sometimes we want to interrupt that. Again, sometimes, right? So I don't do that, for example, when I'm doing exposure therapy. I probably wouldn't do it with panic disorder. I might pull this out for like generalized anxiety. But the idea here is we're going to use what's called progressive muscle relaxation, which is, you know, you sit in a chair, you get a relaxed posture, have the patient close their eyes, and you just start tensing and relaxing muscle groups. You're just going systematically through the body. Hold it for about 5 seconds to tense it, then relax it for about 10 seconds, right? The idea is I'm just teaching the patient to calm down their peripheral physiology, thereby hopefully interrupting that feedback loop back up to the brain, because the brain keeps noticing the arousal and going, oh, there must be a threat here somewhere. Sometimes I might do some breathing retraining. Now, the breathing retraining here, it usually involves trying to slow down oxygen intake. Sometimes when we do breathing retraining, we might encourage the patient, take a big, deep cleansing breath. But the problem that we have with anxious patients, especially those who are prone to panic disorder, is that they're often just on the verge of hyperventilation. So taking a big sucking breath probably adds to the problem. It doesn't actually resolve anything. So what I'm really trying to do is get them to slow the breathing down, right? So I might have them count in as they breathe in through their nose, count while they breathe in through their nose for about 4 seconds, and then count for 6 seconds as they breathe out through their mouth. So it's just nice and slow breathing, right? But again, not for everybody, and probably not within the context of exposure therapy. Okay, here's the part that I mentioned, right? So sometimes the relaxation, the breathing, exercises are not very helpful, right? Like it's a crutch when you're doing it with an exposure for panic disorder. It can potentially reinforce the belief of I better relax or else. The other piece too that I'll just sort of note about doing extensive work in relaxation training is opportunity cost, right? I mean, the reality is you have a finite amount of time with your patient. And it makes sense to spend the majority of your time doing those things that are going to be most effective for them. And relaxation may not be it for a lot of the patients. So a viable alternative to that, instead of trying to get them to resolve their physiological arousal, is acceptance. What I mean by that is that we try to teach our patient that unpleasant or unwanted thoughts and feelings are an unavoidable part of life. Right? I mean, those happen. I mean, we all have things that we don't like in terms of how we feel and what we think. What is really distressing is how you're reacting to those thoughts and feelings. And in particular, our anxious patients try way too hard to fix their feelings, or they try to get away from them. And that, of course, does more harm than good. So what we then go to is some sort of intervention based on this, in which we try to help the patient to recognize that your efforts to try to control your thoughts and feelings have become part of the problem. So what I want you to do is I want you to instead to pay attention to your thoughts and feelings, but identify them as just thoughts and feelings. They're not facts. They're not things that are happening to you. This is just how you feel. It's just the signal inside your brain. So if you do have a thought, I want you to just accept it. Don't judge it. Don't label it. Don't try to control it. Just go, yeah, there it is. Now, as part of this, also what I'm trying to do is I'm helping the patients kind of direct their attention toward the present moment, right? So kind of what's going on right now? What are you doing? Especially what are you doing in your head, right? And what I might start to suggest to the patient is to take all that time and energy that you're currently spending trying to get control of your thoughts and feelings and put that time and energy into some value-based behavior. Like, what do you really want out of life? What do you want your life to look like? Okay, let's take all the time that you're spending trying to calm down and instead take that time and go do that life that you really want. And that actually can be very helpful for a lot of patients, right? Just get them off of that endless unproductive scramble to try to feel better and get them back into their life. Let's have you start doing things that are valuable to you. So this is kind of in contrast to cognitive restructuring, right? Cognitive restructuring, which is challenging cognitive distortions, the rationale is that you should change your thoughts because thinking correctly will help you feel better. And that is absolutely true. But also equally true on the right side is the acceptance rationale, which is that you should change how you react to your thoughts, and that accepting those thoughts rather than fighting them is going to help you to feel better. And I want you to just recognize that your thoughts are only thoughts. They don't necessarily have to mean something. The one metaphor that I'll sometimes use is the Chinese finger trap. You remember playing with this when you were a kid, right? You put your fingers in and then you try to pull out and it just tightens up and you can't get out. There is a way out of the Chinese finger trap, but the way out is to actually push into it so it loosens up and then you can kind of wiggle your way out, right? So I might use that metaphor to talk to my patient, right? You're trying really hard to pull out of your anxiety, and the more you do that, the tighter it gets around you, right? So we kind of need to give up on that strategy. The real strategy, the real way to get out of this is to actually push into it. But what I mean by that is you're probably going to have to be willing to feel bad in order to feel better. Another way of kind of thinking about this sort of acceptance-based rationale, Doug Menon and Dave Fresco has this great idea of primary versus secondary emotions, and they describe it using the metaphor of a snowball, right, at the top of a hill. So that's your emotion. Let's call it fear. Now, that's normal. That's healthy. It's even necessary because you'd be dead if you didn't have it, right? So there's nothing wrong with fear. There's nothing wrong with having that emotion. The problem is, if you kind of go back to our metaphor of the snowball starts to roll downhill. And as it rolls downhill, it rolls through a bunch of leaves and sticks and dog poop and stuff like that. And you end up with this big, nasty slush ball at the bottom of the hill. Now, what are those leaves and sticks and dog poop? The leaves and sticks and dog poop is the patient's struggle against anxiety. It's their unwillingness to feel it. It's their attempts, their scramble to feel better, no matter what that does to them, right? That's what makes the big nasty problem. So what we're kind of trying to help the patient to do is recognize that the emotion itself is not bad and you don't have to do anything about it. Well, the real problem is all of this struggle that you've been doing against your anxiety. That's what's turned this into a big nasty problem. I'll skip a couple here. So again, just kind of going back to this idea of emotions, right? Help the patient to sort of recognize as you're trying to control your emotions, that's become part of the problem. So I want you to learn to accept your emotions, be willing to make room for them without saying that they're good or bad or anything like that, right? There's no such thing as a bad emotion. There's no such thing as a bad thought. They're just internal events. And then the last kind of core component that I'll talk about is the skill training, right? How do you train any skill? Well, you assess how well the client can do it. You give them some instructions. You may model it and demonstrate the skill. You have them practice it. And then you give them feedback, right? So we talk about social skills, like assertion. We may want to get the patient to be able to make requests of other people and refuse unreasonable requests or communicate strong opinions and feelings. So we might take that as an example and we might do like a role play. Well, all right, let's try being in that situation that was so problematic for you. And let's have you kind of practice asserting yourself. Maybe I'll start and I'll try it first and you watch me. And then we can talk about how I did, and then you try it, and I'll give you some feedback on how you seem to do. On the problem-solving training, remember I mentioned those basic elements, but each of those is a skill that you can teach the patient, right? I mean, well, the first is sort of a therapeutic style, just promoting that problem orientation. But again, you can have the patient sort of define what the problem is, brainstorm solutions, decide on a solution, and then try it out and come back and see if that worked, right? It's a great alternative to what they're often doing, which is just spinning around in their head with this stuff. So let's talk about how this goes, with regard to specific anxiety-related disorders, right? There's a long list of these, and I don't know what the DSM-5 did with breaking this stuff all up, but these are all anxiety-related, right? OCD, PTSD, illness, anxiety, even though they are not listed under the anxiety disorders, they kind of are, right? So let's talk about what we do with some of these disorders. Panic disorder, right? These are the panic attacks that come out of the blue. And so the person is having all of these panic attacks where their heart's racing and so on. Its behavioral cousin is agoraphobia. That's tricky because it literally translates to fear of open places, which is not really what it is. It's a fear of panic attacks, right? The person is afraid that they're going to panic, that they won't be able to escape and they won't be able to get help. So they kind of pull back on their behavior. So let's kind of come back to our conceptualization, right? What seems to be driving panic and agoraphobia? Well, for me, I think a lot of it comes down to cognition, right? That what's happening is that our panicky patients are engaging in catastrophic misinterpretation of their own physiological sensations. So when they feel dizzy, it's not just, oh, I'm dizzy. It's no, I'm dizzy and that means I'm going to faint. When they have increased heart rate, it's not just, oh, my heart's racing. It's, nope, I'm about to have a heart attack, right? That's that catastrophic misinterpretation. So that magnifies the fear. And then again, avoidance, right? We know how toxic avoidance is. And as the person engages in agoraphobic avoidance, that magnifies the fear over time. So what do patients with panic disorder and agoraphobia need? Well, okay, just going back to our basic conceptualization, right? Well, if the problem is that they have catastrophic beliefs about their physiological sensations, then we need to reduce those catastrophic beliefs. And if part of the problem is that the patient is engaging in agoraphobic avoidance, then we need to reverse that, right? Get out of the avoidance. So what are we talking about in panic disorder and agoraphobia? We're talking about exposure to, like in vivo exposure to feared situations. Let's go to the mall without safety behaviors. Let's drive. Let's get in the elevator. As well as exposure to feared sensations. That's the interoceptive exposure, right? Okay, if what you're really afraid of is being dizzy, then let's spin around and get dizzy until you're not so scared of it anymore. And in many cases, they may benefit from some cognitive restructuring of their maladaptive beliefs. Right? Let's really take a look at what you're saying about these sensations and situations, and let's see if that's really accurate or not. So this is just kind of interoceptive exercise. I'm going to skip this part. Interoceptive exercises. There's a lot of things you can do to kind of stimulate physiological arousal. How about if your patient has social phobia? Right. This is the patient who's afraid of being embarrassed or humiliated. They're afraid that they're going to look foolish or stupid or anxious. What's driving that? Well, again, there's a belief, right, that my actions are going to be embarrassing, and there's a low tolerance for that embarrassment. So if I do get embarrassed, it's going to be horrible and the end of the world. Sometimes also we see compounding the problem in social phobias that the person has some social skill deficits, right? They're maybe not good at some of the things they're afraid of. And then, of course, they avoid, and that magnifies the fear over time. So what do people with social phobia need? You need to reduce that belief that their activities will be embarrassing. You need to increase their capacity to tolerate some embarrassment, and you need to pull them back from that avoidance. So what are we talking about? Exposure to potentially embarrassing situations or activities so they can see it goes okay. Some cognitive restructuring that help them recognize that even if they do get embarrassed, it's not the end of the world. It's not devastating. And depending on the patient, they may need some social skill training to practice how to do specific interactions or specific activities. Specific phobia, dogs, heights, etc. What's driving that, right? Well, probably two things. One is the person probably overpredicts that the situation is really dangerous. And two, the avoidance tends to magnify the fear over time. So again, what does your patient with dog phobia need? Well, we need to get them to not believe that dogs are dangerous, or at least not so dangerous, and we need to get them to stop avoiding. And that's an exposure. That's an in vivo exposure, right? Let's have you come closer and closer to dogs until eventually you're able to encounter them without experiencing a great deal of fear. How about GAD? These are the patients with, persistent uncontrollable worry. And as a result, they're persistently physiologically aroused. What's driving that? Well, there's probably distorted beliefs, right? So there's this tendency to believe that things are more threatening than they really are. But also that hyperarousal probably contributes to more brain activity. And the other thing that I'll mention here is there tends in GAD to be a problem-solving deficit, right? That what the person is often doing in GAD is they're using worry as a form of pseudo problem solving. It doesn't really solve any problems. It just kind of churns around in their head. But they think they're solving the problem. So what do people with GAD need? They need to not see things as so threatening. We need to reduce that hyperarousal, and we need to decrease their tendency to use worry as a substitute for problem solving. So what would you do with GAD? Some cognitive restructuring, maybe some relaxation training here to reduce that physiological arousal and disrupt the feedback loop, and maybe some problem solving training so that you don't have to keep relying on worry as a coping strategy, and instead you can actually try to solve things as they come up. OCD, right? These are the obsessions, the compulsions. What drives it? Well, one is that a patient with OCD often has a fear of their own thoughts, right? So they may say, if I have this thought, it means I'm crazy or I'm dangerous, I'm bad. They may have exaggerated beliefs about the threats that are in the environment. And of course, avoidance magnifies that fear over time. Right. And again, remember, compulsion safety behaviors are a form of avoidance. And those attempts to avoid negative thoughts, they just habitually backfire, right? Try not to think about an elephant, and what's the first thing that comes to mind? It's an elephant, right? So try not to think about being a child molester. Well, that's going to come to mind, right? So trying really hard not to think something actually backfires and makes it worse. So what do people with OCD need? Well, they need to reduce that fear, and they need to reduce their avoidance. And that's exposure and response prevention, right? Let's get them in touch with the things that are scary or the thoughts that are scary. And let's have them hold back on doing compulsive behaviors that make them feel better. A couple more. PTSD, right? We all know PTSD, right? What's driving PTSD? And again, remember, the why is maintenance, right? So it's easy to go to etiology and say, well, PTSD is there because of trauma. That's not a terribly satisfying answer from a CBT perspective. We want to know what's propping this up. And what's propping it up is a fear of trauma memories, right? For example, the patient may believe, I can't handle thinking about my trauma. Well, and of course, just as we saw with elephants, avoiding a thought tends to make it worse, makes you think about it even more. The people with PTSD are also afraid of their trauma reminders, and the avoidance maintains the fear. And they may have really distorted or negative beliefs about themselves or other people or the world. So what do people with PTSD need? Well, they need to reduce their avoidance of trauma memories. They need to reduce their avoidance of feared situations or activities. They need to decrease some of those pervasive negative beliefs about themselves or other people or the world. So how do we accomplish that? Well, as you might guess, exposure is going to be a big piece of this. And part of that involves exposure to the trauma memories. You know, we're not trying to distract you away from memories of your trauma. We're doing the opposite. I want you to talk about it. I want you to think about it. It's good and healthy to do it because that's how you process it, right? If you avoid it, it's going to stay in this very undigested state. So let's think about and talk about your trauma. And let's also have you approach those feared situations or activities, so long as they're not objectively dangerous. And let's do some cognitive restructuring for some of those negative beliefs. Now, I'm going to skip a couple of these with the illness anxiety because I do want to make sure I leave time for questions. So let me just go to my summary here. All right, in CBT for anxiety, as well as CBT for just about anything, in our case conceptualization, which I think is all important, we tend to focus on the maintaining factors, right? What's not where did the problem come from originally, but what continues to prop this up? And the usual suspects here are avoidance of feared stimuli, again, either internal or external, maladaptive beliefs about things that the person feels are threatening, that feedback loop of physiological arousal, and sometimes behavioral skill deficits. So the core CBT principles that we're talking about are exposure to those things that the patient is avoiding, correcting maladaptive beliefs sometimes, although I think an argument could also be made for just accepting those maladaptive beliefs and just recognizing, hey, that's just a thought. For some patients, relaxation training, again, with some caveats, right? You don't want that to turn into a crutch. And for some patients, I think especially for our patients with social phobia who may have a social skill deficit, or our patients with GAD who may have a problem-solving deficit, they may benefit from some skill training. So if we sort of think about the specific anxiety disorders, right, what does CBT come down to, right? With panic and agoraphobia, what you really want to be emphasizing is both interoceptive exposure and in vivo exposure. For social phobia, you want to emphasize in vivo exposure along with cognitive restructuring and, depending on the patient, some social skill training. Specific phobia, straight up in vivo exposure when you can do it. GAD, some cognitive restructuring, but again, acceptance is a viable alternative, right? But let's do something about those negative thoughts. Perhaps some relaxation training for that patient, and maybe some problem-solving training to get them off of worrying. OCD, very clearly, right? It's exposure with response prevention. PTSD, it's that imaginal and in vivo exposure. So like, let's deliberately think about and talk about your trauma and do the things that you're finding scary, as well as cognitive restructuring. And then there's illness anxiety disorder that I didn't talk about, but I'll just mention within the illness anxiety, you know, it again comes down largely to an exposure with response prevention. And again, if you want to do something with the negative beliefs, and it does make sense to do so, you could either try a cognitive restructuring or an acceptance-based approach. And with that, I just want to say thank you very much for your attention, and I'm happy to open it up to questions now. Here, I'll turn off the share here so I can see all your smiling faces. So what questions come up? I assume then that it's all very, very clear.
So, Dr. Tolin, I know CBT, is it's a pretty good tool in treating anxiety disorders. Is there any other therapy that or into CBT treatment, or find yourself coordinating with other specialists in the treatment of, I don't know, say PTSD or generalized anxiety disorder, or panic attacks, that kind of stuff?
Yeah, I think if I understand your question, that certainly there is a place for example, pharmacotherapy
Yep.
in treatment of many, if not all, of the anxiety disorders, and often very close collaboration with the pharmacotherapist makes sense.
Yeah,
And
not pharmacotherapy,
yeah,
but other types of therapy. I know you said you did, I know you do a lot of different things at the Anxiety Disorder Center, but I'm wondering about DBT or, just other psychological therapies.
Sure. And I want to tread lightly here, because what I really don't want to do is bash other forms of therapy. So I'm going to try to be gentle with this. But what I'm going to say is this, that the evidence base, the scientific evidence base for other forms of psychotherapy for anxiety disorders is not good. There is a smidgen of evidence, and it really is a smidgen, suggesting that for some patients, psychodynamic therapy may be helpful. But the evidence base isn't nearly what you have for CBT. Within the area of PTSD, I know there are a lot of people who like to use eye movement desensitization and reprocessing.
Yep.
They are. The problem that I have with that, I mean, it's not like it doesn't work. I mean, it does pretty much. The evidence suggests that it's maybe as good as CBT, maybe not quite as good. That's what the randomized controlled trials are telling us. It certainly is not the miracle cure that was being sold. The problem that I have really with like EMDR is that when you look at the dismantling research, there's no evidence that eye movements do a thing. They really don't help. So we're kind of basing an entire treatment on something that's not true. With this idea that eye movements will accelerate your information processing, there's no evidence that that's true. And in fact, a lot of evidence that suggests that it's not true. So, I like to be very straightforward with the treatment approach, and I like to emphasize things that are demonstrably true. And what is demonstrably true is that avoidance is bad for you, and avoidance is really causing you to continue to have this problem. And so if we, and again, what is also demonstrably true is that if we undercut that avoidance, you're probably going to end up feeling better. So kind of coming back to your question, Joe, and again, I was promising not to bash other psychotherapies, and I realize I may have just done so. But kind of coming back to your question about how do you coordinate with people who are doing other kinds of therapy, a part of what I try to do is sort of figure out, regardless of what we call it, what are the common themes of what we're doing. So even within, for example, psychodynamic therapy, or even within EMDR, a big piece of what we're all doing is exposure. We have different, we call it different things. Those guys don't call it exposure, but they're still kind of doing it. Even Sigmund Freud said, eventually you got to face the thing you're afraid of. So I think we can kind of all agree on some core principles of treatment, even if we don't necessarily agree on how that treatment is delivered.
No, thank you. And then one more question: augmented reality and things like the metaverse. Do you see a place for that in the type of therapy that you do with exposure therapy?
Well, potentially. I mean, I don't know a whole lot about augmented reality. I know we sort of use like virtual reality, and it's a way of kind of helping the patient to get in touch with things that are scary that you can't realistically do in an in vivo level. So I kind of gave the example of you can, it would be cost prohibitive to send the patient on multiple flights. But what you could do is give them virtual flights and have them do that over and over again. We do the same thing with public speaking. So, I love the idea of gathering an audience and having the patient give a speech, but sometimes that's really hard to do. So we can use virtual reality to have them give a speech in front of a large audience and have them practice doing that. I don't know, did that get at the question?
That answers it. Yeah, no, thank you.
Yeah.
So any other questions from the group? That was a great presentation, by the way.
Thank you.
And we will have a copy of it for folks. I know somebody asked if we could have it for reference. Aaliyah, I think that was you. Mm-hmm. So yeah, no, thank you very much. I guess we'll close out unless anybody has any other questions. And thank you again, Dr. Tolin. It's always a pleasure to see you and learn from you. So
Yeah,
appreciate your time.
my pleasure. Well, it was nice talking with all of you. Thanks for your attention.
Thank you.